non-muscle invasive bladder cancer, non-papillary appearance, and suspected or non-CIS. Next, we go to bladder histoanatomic variation. Because of its contractility, the depth of different side of tumor or the thickness is much different. For example, here, the dome has thickest lamina propria, whereas the trigone and neck has the thinnest lamina propria. So this is important for us because sometimes we do get specimen from trigone. So bear in mind, they have the thinnest lamina propria, and so the muscularis propria is very superficial. This just the image just to show you that muscularis propria in trigone, whereby the muscularis propria in trigone is more superficial. It's more superficial and is thinner. And here is the ureteral insertion, whereby the ureteral muscle is smaller and is surrounded by muscularis propria of bladder within the bladder wall. Pathological staging is the single most important prognostic and predictive indicator in bladder cancer. So I think everyone is familiar with this. We have TIS, the urothelial carcinoma in situ, TA for non-invasive papillary urothelial carcinoma, T1 for invasive into lamina propria, T2A for invasive into inner half of muscularis propria, T2B for invasive into outer half of muscularis propria, T3A for microscopic invasion into perivesical soft tissue, and T3B for macroscopic invasion into perivesical soft tissue, and PT4 is for invasion into adjacent organ. Okay, it's very important for us to give an accurate staging, whether it's TA, TIS, or T1 or T2, because it's very crucial for the clinician or for the surgeon to stratify patient into which risk group. Okay, for example, here for all, if patient have CIS only, so this patient is fall into high risk group. Even if it's not muscle invasive, for example, TA high grade 3 with concurrent CIS is already fall into high grade risk. Okay, so this is very important for us to give accurate staging, because based on this, they will recommend for management and further treatment. So just to highlight here, as I mentioned just now, even it's not muscle invasive, TA high grade 3 with concurrent CIS, actually is already warrant the surgeon, the treatment, give green light to the surgeon that the treatment would be radical cystectomy if a patient consented for it. Now we go to staging TA, or the non-invasive papillary urothelial carcinoma. So one can misdiagnose these TA tumors as TIS or T1. For example, in truncated high-grade papillary urothelial carcinoma after treatment, high-grade urothelial carcinoma with early papillary lesion, flat shoulder of high-grade papillary urothelial carcinoma in separate TUR fragments, or even inverted high-grade papillary urothelial carcinoma with inverted pattern that mimicking invasion as T1. So this is just to show the analogy of carcinoma in situ. with high-grade papillary urothelial carcinoma. As we know that they both have high-grade cytology, widespread nucleomegaly, and beast mitosis. So how to differentiate between these two? So we have to ask the surgeon what is the cystoscopy findings, okay? Because in CIS, we usually only, they usually saw only the reddish velvet that can be indistinguishable with inflammation. Okay, now we look here. So this image show, is it flat or is it papillary? So for this type of lesion, the GUPS group call it as CRS with early papillary formation. And just to remind you that if you want to call papillary urothelial carcinoma, they should have thickened urothelium, slender core, not dented, and vessels at core tip. This is another problem. Sometimes we do receive specimen that is poorly orientated, and flat shoulder of high-grade papillary urothelial carcinoma may mimic CIS or TIS. Okay, for example, the specimen is taken from here. When you look under microscope, you can't see any papillae or even fibrobascular core. So you might call it as CIS. Okay, this is to share with you in this image. This is actually high-grade papillary urothelial carcinoma, high-grade non-invasive papillary urothelial carcinoma. And in this area, you can appreciate this CIS. So whether to call it CIS or whether to call it flat shoulder of high-grade papillary carcinoma. In my experience doing clinical urology attachment, actually the surgeon will sample using different containers for cases they suspected of CIS adjacent to the tumor. So we should advise the surgeon to put end mapping biopsies in different containers. So as I mentioned just now, even non-invasive, non-muscle invasive high-grade TA with concurrent TIS or carcinoma in situ, actually is a green light for the surgeon to do cystectomy. Another problem in staging is actually the inverted lesion. So I just share this table to for us to recall back the difference between inverted papilloma, inverted panlum, inverted papillary urothelial carcinoma, non-invasive low-grade and high-grade. So we have to look for its morphology features, whether they have this exogenous papillary structure, endogenous nest and trabeculae, cellular layers, central umbilical cells, polarity, cellular atypia, and mitotic figures. So these features are very important for us to know to differentiate between these four. This is typical inverted papilloma. I think everybody can diagnose it. Typical inverted papilloma, they have this thin trabeculae with central streaming, peripheral palisading cells, and there is no cellular atypia. For this one, this is it lamina propria invasion here? So this is actually inverted urothelial papillary urothelial carcinoma, non-invasive, where this one might misdiagnose this as invasion, but here we can appreciate that it could be tangential cut, whereby here we see this nest have smooth border, and we can see the clear demarcation between the epithelial endostroma, and there's no stroma response. As compared here, this is obviously lamina propria invasion. Remember, not all growths into lamina propria are invasive. For example, this is the low-grade papillary urothelial carcinoma, non-invasive. They show this regular smooth contour, usually bulbous, and sharp epithelial stroma interface. They don't have the irregular jaggedness, single cells, paradoxical squamous features, or stroma invasion. So this is actually inverted growth of low-grade papillary urothelial carcinoma. Okay, this one, just to show you the images of obviously high-grade papillary urothelial carcinoma with lamina propria invasion. And now we go to staging in TIS tumor. Scenario that can lead to misdiagnosis, for example, CIS extending into von Brunnes, cystitis cystica, or cystitis glandularis. One may misdiagnose as T2 or TA. Another scenario is CIS along undulating mucosa of host, is diagnosed as TA. For this one, I would like to show CIS involving von Brunnes. It's like CIN3 involving the endocervical gland. So it can mimic lamina propria invasion or inverted papillary urothelial carcinoma TA. Okay, so hint for this one is actually if we compare to the inverted growth, they have this flat surface, rounded contour, spaced out, and lobulated here. You can appreciate it's lobulated. And von Brunnes is located at the superficial of lamina propria. And sometimes you can appreciate the adjacent benign von Brunnes. Same goes to CIS in cystitis cystica at glandularis. It can mimic lamina propria invasion. Other than that I mentioned just now is CIS along undulating mucosa of host, TIS, can mimic non-invasive papillary urothelial carcinoma. So again, for papillary urothelial carcinoma, is thickened urothelium, slender core, and vessel at the core tip. This one is more tented. Another problem that we may encounter is the subtle CIS. For example, focal pagetoid CIS, cleaning CIS, but we can do immunostain of CK20 to help us to highlight these CIS cells. Now we go to the next one, issues in staging T1 tumors. In here, mostly people would upgrade the tumor, misdiagnosis as T2 or T3. For example, urothelial carcinoma invading hyperplastic thick muscularis mucosae, urothelial carcinoma involving diverticular wall, diverticular tumor, or urothelial carcinoma involving lamina propria adipose tissue. Okay, just for us to recall back the criteria for diagnosis of invasion into the lamina propria. So we look into these two, the invading epithelium or the stromal response. For invading epithelium, usually the cells are of higher nuclear grade. They have irregular shaped nest, single cell infiltration, irregular or absent basement membrane, and they sometimes have finger-like projection. For stromal response, you look for desmoplasia or fibrotic stroma, retraction artifact, inflammation, myxoid stroma or pseudosarcomatous stroma. Okay, this just to remind you that in TRBT specimen, sometimes it's very difficult because the orientation is not, we are not sure the orientation, but just remind this, for lamina propria layer, the muscularis mucosae is actually towards the surface. Sometimes they do undergone hyperplastic change, but they usually few, and you can see adjacent vascular plexus towards it, and you do see adipose tissue within lamina propria, and don't diagnose T3, PT3 in TURBT specimen. Okay, this is just to show you the T1 involving hyperplastic muscularis mucosa. The one in the one showing by this arrow is actually the hyperplastic muscularis mucosa, and we can appreciate the adjacent vascular plexus. The clue, the muscle is actually muscularis mucosa rather than muscularis propria. Now we go staging tumors in bladder diverticulum. As we all know that diverticulum in adult are usually acquired. So they are lack of muscularis propria. So bear in mind that if bladder diverticulum develop urothelial carcinoma, we don't have the P2 staging. So they have PT1, PT3, and probably PT4. So this just to show you the bladder diverticulum with urothelial carcinoma that invade into the peridiverticular soft tissue. Now we go to staging of T2. Okay, T2 is the muscularis propria invasion. Okay, one can misdiagnose it as T1 because it's fractured muscularis propria by urothelial carcinoma. Carcinoma infiltrating between but not into muscularis propria bundles is considered as T2, not T1. Carcinoma infiltrating adipose tissue between muscularis propria bundles is T2, not T3A. And invasion of prostate parenchyma via intraurethral spread of bladder cancer is not T4, but is T2. So this is the example of muscularis propria fraction and dispersed by cancer is T2. It may mimic the hyperplastic muscularis mucosae, but mind you, usually the muscularis mucosae will be located near the surface. They also will disorganize, but they are not abundant like this. They are few only, and you can see adjacent vessel to the muscularis propria, not like this. So consider the overall muscularis bundles control to determine whether it's muscularis propria or muscularis mucosae. Okay, is this T2? I think I've mentioned before just now, if the tumor nest is infiltrating in between the muscularis propria bundles, the thick bundles here, this is considered T2. How about this one? Is this T2? This is again T2 when the tumor surrounding the muscularis propria is considered T2. It's not just the tumor infiltrating into the muscularis propria. Okay, this one just to share the image of invasive cancer involving fat within muscularis propria layer, T2, not T3. So you can see here that this nest actually already infiltrate in between the adipose tissue and also in between the muscularis propria. So this is T2. Okay, bladder cancer staging is by depth of invasion. So please remember, adipose tissue often present in lamina propria and in between layers of muscularis propria. Therefore, don't label PT3 into TURBT specimen. So if tumor is here, is this T2 or is this T3? So where is the muscularis propria layer? So because of the irregularity deposition of muscularis propria and abundance of adipose tissue, the boundary is actually not well demarcated. So most experts actually make a line here, okay, at the irregular outline of the muscularis propria. They make one line here, sambung, okay. So and some other expert took this the outermost of muscularis propria and draw a line to determine staging whether it's PT2B or PT3A. Sorry. So if the tumor is beyond this line, they call it as PT3A. So if it's within here, so it will be PT2B. Okay. So this just to show you the T2 invasion. This is the muscularis propria bundles, and this is scan here. And they draw one straight line here so that they can appreciate that this is actually T2, whereby the tumor already infiltrate in between the muscularis propria. So how about prostatic invasion in TUR? In TUR, prostatic chip, it is not recommended to automatically stage as PT4A unless you are sure or clinically detected there is transmural extension. This just to the cartoon for us to remember that bladder cancer with prostatic stromal involvement via two routes, okay, intraurethral or transmural. Transmural from bladder wall infiltrate into the prostate, or from bladder wall into the perivesicular soft tissue into the prostate. So this just image for T1 bladder cancer, T2 urothelial cancer, and T4A bladder cancer. Okay, now we go to T1 subcategorization in TURBT. I think some of us or many of us have heard about T1 subcategorization. In many research actually show significant upstaging of T1 tumors in radical cystectomy, up to 50% upstage to more than T2, 33% upstage to non-organ confined disease. So there is heterogeneity of prognosis of T1 tumors. So many study has been done since 1945, and they group this subcategorization into histoanatomic techniques use landmarks, micrometric techniques use measurement, and other techniques by approximation use the practicality, whether it's focal or non-focal. For histoanatomic T1 subcategorization, They uses muscularis mucosae and or vascular plexus as landmark. Some use three-tiered classification or subcategorization above T1A, into T1A, or below T1C. For two-tier, above T1 or below T1. But because of the orientation is sometimes very difficult, so some suggest to use this micrometric T1 subcategorization. So they divide T1 into less or equivalent to 0.5 as microinvasive, more than 0.5 as extensive. So for multifocal invasion, they regarded as T1E. Other T1 cutoff or methods, some use aggregates linear length of invasive cancer, whereby they measure the length of the invasive component. And then they use 1 mm or 1.5 mm cutoff. Micrometrics actually appear superior than histoanatomy based on feasibility and predictive of outcome. So AGCC, WHO 2022 and GAPS 2021 actually recommends T1 subcategorization in TURBT. However, no single method was suggested. And so we are, as pathologists, we are recommended to subcategorize of PT1 by measure or estimate of extent of lamina propria invasion. But during my attachment in UK, they never categorize the T1. So in future, actually, they need well-designed prospective studies with head-to-head comparison. They have standardization of TRBT processing, and methods should be able to identify highest risk of T1. This is towards my last slide, actually. The use of muscle immunohistochemical stain for staging TRBT. I think everyone knows about it, but I don't think in Malaysia we have smoothering. I don't know if any of government hospital has it. So smoothering suggested to stain muscularis propria strongly, but limited or absent in muscularis mucosae and myofibroblasts. But it's very challenging to optimize smoothering, including titration and antigen retrieval. In other references, Vimentin also suggested. Vimentin actually show moderate to strong staining for muscularis mucosae, but weak staining in Vimentin, but it's not recommended by ISUP in 2013 because of the limitation. But ISUP 2013 actually recommended Desmin to be used to highlight muscularis propria versus desmoplasia. If you are not sure whether is it desmoplasia or is it muscularis propria, so they recommend to use Desmin because Desmin can outline the muscularis propria contour. So this to show you the muscularis propria bundles that are fractured and dispersed. So sometimes you are difficult to appreciate even the muscularis mucosa muscularis propria invasion. So for this case, they use mottling to highlight the muscle bundles for muscularis propria. So this is my this is end of my slides. As take-home message, please evaluate possible invasion systematically, both invading epithelial and stroma. Stage accurately because the surgeon, the oncologist depend on us for the management and treatment for the patient, especially when they have to decide whether to do cystectomy or not. Okay. for the one, for example that I've mentioned just now, even non-muscle invasive papillary carcinoma, the high-grade papillary urothelial carcinoma with concurrent CIS is actually give green light to them to do cystectomy. So always report muscularis propria status clearly. You mentioned normal muscularis propria present or invasion into muscularis propria absent or present. And do not hesitate to ask to repeat biopsy if uncertain. I think it's good to discuss with them if you are not sure. So this is example for reporting. High-grade invasive urothelial carcinoma, you write invasion into lamina propria present, negative for invasion into lamina propria, normal muscular propria present, CIS present, and negative for invasion. Okay. In my center, the neurosurgeon wants us to put WHO 1973 grading also, because I already asked them, they use the European urology guideline that I share with you just now. Let me show you again. Okay. If you see here, okay, they actually they have grade 2, grade 3. Okay, so because they are still using it, that's why they asked us to give WHO 1973 grading as well to risk certification for the patient. Hope it's clear for everyone. Okay, this other reference. Okay. And thank you for your attention.
Thank you very much to Dr. Suhaila for the insightful presentation. And I agree, sometimes bladder pathology can be so tricky and difficult. Okay. So now we open for the Q&A session. Let me check if there any question in the chat box. Okay. Okay, I think I would like to ask Dr. Suhaila, do you measure the thickness of the muscularis propria? Because in the I think in the certain books it mentioned to differentiate muscularis propria, you have to yeah, certain measurement actually it's supposed to be more than 100 micron. Do you do the I mean in the practice, I mean let's say we don't have immunostains, you know, so is it good to apply?
Based on my experience and during my attachment in UK, I never measure the muscularis propria. So far, I think it's quite straightforward because you can appreciate the thick muscle bundles and is at deeper levels. The problem is when it's hyperplastic and the orientation is very difficult. So for the if the orientation is difficult, so for you to differentiate muscularis propria and muscularis mucosae, I think I mentioned just now, for muscularis propria, usually there is vascular plexus near them, okay, as compared to muscularis propria. Like
Okay, thank you.
this one.
Okay, thank you, Dr. Suhaila, for the answer. I think somebody raised hand from Hidayah Jalani. Would you like to ask the question, Hidayah?
There are 2 questions in the chat box.
Oh, okay. Okay. From the chat box, there's a question from Murni. Assalamualaikum, Dr. Suhaila. If we see tumor at specimen level as tumor base, can we stage the tumor as T2 even if we cannot find muscularis propria?
Okay, if you can't find muscularis propria within the tumor base, you have to say that there is no normal muscularis propria present. You cannot stage as T2 terus. Okay, you have to see the muscularis propria. Even though it's labeled as tumor base, you don't see the muscle, so you report as no normal muscularis propria. See, so they understand there is, so because of you cannot see the muscle, right? So there is no evidence for us to say it's T2. So this is the case that usually they will do second TUR.
Okay, for the next question from Nohidayati, salam doctor, if we receive multiple superficial fragments with muscle invasion, can we say it muscularis mucosae invasion straight away or need to rule out the muscularis propria invasion?
Okay, even though it's superficial, you have to know where is the biopsy or TURBT taken from. As I said, the thickness of muscularis propria, lamina propria is different within the sides of bladder. So for example, the one that I showed just now is trigon, right? So trigon have very thin, the thinnest lamina propria. So the muscularis propria is quite superficial. So you have to use the criteria that I mentioned to say it is muscularis propria invasion or it is muscularis mucosa invasion based on the criteria. You cannot straight away it is muscularis mucosa invasion. So you have to think of the area where is the area taken from, and then the criteria that I mentioned just now.
Okay,
Assalamualaikum, Dr. Suhaila, Natasha here. I'd like to ask regarding your experience in UK. Do they put staging at the interpretation, whether it's PT1, PT2, at the TURBT specimen?
Okay, they do stage the TURBT specimen. Usually, if they saw the muscularis propria invasion, they will put at least PT2. I think the usual practice here, right? Biasanya kita akan letak at least PT2.
No, in HKL we don't practice putting the stage at all. I remember
Okay.
I asked the one of the speaker, and they actually advise not to put staging at the TURBT specimen. So I would like to know the current updates.
For me, in Kuantan, I didn't put, but in UK, they do practice. They put at least PT2 if they saw the muscularis propria invasion. But logically, I think it's safer not to.
Thank you.
okay. I think we go to the next question from Wan Shahira. When urothelial CA is found incidentally in a TURBT specimen done for BPH, do you advise to submit all the tissue? What if we would get too many slides, for example, more than 30 to 40 sections?
Actually, if you are not sure, if you can't find, even if you can't find muscularis propria in the TURBT specimen, you have to submit all. I have experience in HKL. The surgeons say the suspect is PT2, but there is no evidence of muscularis propria invasion. So we have to submit all 46 slides. I remember it's 46 slides. to give them the appropriate or accurate diagnosis, because they depend on us for the staging. They really depend on us for the staging. So that's why sometimes if for all T1 tumors, they will do second TUR. Because staging is very important for them for prognosis and predictive indicator.
Okay, hope that answered the question. Okay, for the next one, in biopsy cases with mixture of high grade and low grade urothelial carcinoma, do you report the majority population or take the higher grade?
Okay, in my experience, actually it depends on where you practice. If you practice in US, for example, if you do see high grade more than, if I'm not mistaken, more than 10%, the label is high grade. But in Europe and UK, they rather put low grade urothelial carcinoma with focal high grade, how many percent? But I do practice using the UK and Europe rather than US, because sometimes you only see very focal, right? 5%, 10%, and the majority is actually the high grade is actually grade 2 rather than grade 3. So it's very hard actually for the surgeon to make decision for the risk classification. I hope I answered the report. I will put low grade urothelial carcinoma with focal high grade, how many percent?
Is there any more question from the audience? Dr.
Dr.
Suhaila,
Suhaila,
okay.
I have one question. I mean, we've been preaching saying that CK20 to show any evidence for dysplasia. In your practice, how frequent do you use? Because I mean, my experience, I don't know, maybe my lab coat, I'm not sure, but somehow CK20 not really reliable at times.
I agree,
agree with
Zara.
you,
It's actually
Yeah.
CK20 is not reliable. Sometimes we expect it to be positive, is negative. So we have to go to morphology and correlate with the findings.
Do you use any other stains apart from CK20?
Sometimes I do because usually I do CK20 and P53, but sometimes it doesn't help.
Wow, betul. I use the same as well, P53. At times, kalau rasa sangat KI, but most of 53 and 20 lah, but 20 really does not help.
Yeah.
Oh,
Even Prof Penner, is it Penner? The one from US, they have this similar problem. So sometimes CK20 doesn't help you much.
ada in some books they propagate CK, I think CK44, right? But kita tak ada, right? Nobody
Kita
has
tak
that.
ada.
Kalau Desmin, Dr. Suhaila, how frequent you use that? I do use it because I found it quite reliable lah to see the architecture of the muscle, especially yang muscle yang being fragmented by the tumor. And you have, because sometimes my MO tanya kenapa tak buat guna SMA, though I do have to tell them like, because desmoplastic, collagenous, fibroblast, nanti you cannot differentiate. So
Yeah.
how frequent do you use that as well to outline the muscle structure?
so far, I think I never use Desmin because Alhamdulillah lah, I get the quite strict criteria for muscularis propria. So I don't have experience using Desmin. Even in UK, they rarely use Desmin.
How about deeper? I mean, do you do deeper section? I mean, let's say kan, actually how how much deeper I mean to evaluate the muscularis propria tu?
How much deeper?
Ah,
Kalau Zara biasa, kalau I have this suspicion, I cannot say lah how much deeper ke apa. It's more like
Yeah.
eating. If you
If
see
you-
kan macam suspicious je, you buat deeper. Sama
Yes.
juga kalau lamina propria tu. Because dia macam iffy tu, I do
Yeah.
deeper. Most of the time, it turns out memang actually ada invasion.
Betul,
Oh,
betul.
okay,
I agree with
okay.
Zara.
Yes.
It depends. It depends. You cannot say until habis tissue kan. So it depends. So I also have the same experience as Zara lah. You rasa this area is invasion and you buat deeper memang true enough is invasion.
Alright, okay.
Yeah, I would like to share my experience with Desmin. Actually, I find Desmin is very useful when the TURBT specimen is very harsh, with marked portrait artifact, and when there are area necrosis, it really helps to highlight the muscle bundles.
Thank you, Natasha.
Good. So, any more questions from the audience? I think I think if there is no more question, okay, I would like to thank you to Dr. Suhaila, okay, for the very, very interesting presentation. Okay, hopefully it clear our doubt. Okay, I think we reached to the end of the event. Okay, thank you everyone who are attending this talk. So enjoy the long weekend. Happy holidays and happy Deepavali to those celebrating. Okay, thank you very much.
Thank you so much. I hope it's benefits to all.
Thank you.
Okay, thank you.
For next month punya talk, we will update if any changes in the program. So please look out in our WhatsApp group for any changes and updates. Thank you.
Thank you, Zara.
Thank you, Kak Suhaila. Very informative. Tak payahlah Zara baca banyak-banyak. Sebab akak dah summarizekan. Thank you very much.
Dr. Suhaila nak tanya satu undercover, boleh tak?
Boleh.
Nak tanya presentation ni nanti
Nak apa? Nanti I share ke mana?
Share PowerPoint
Share
very interesting, very informative.
Actually, it's out of the topic. Tapi nak tanya tu segan pula.
Proses tanya je lah. Dah habis ni.
Nak tanya
tanya boleh, kalau I boleh jawab. Kita discuss.
Approach to glandular neoplasm of bladder. How to approach to a glandular neoplasm of bladder. Alright, kita make it for next topic lah.